So cholesterol in and of itself is not bad. It's actually very necessary and very important for us. It's just that some of us are out of balance, and a lot of it has to relate to genetics and the way that we eat. So if we understand that we can affect it by the way that we eat, that's fantastic. But now we have even better testing where we can look and we can see, what our situation was and what we got handed to us genetically. Just like you would go and you would take any other genetic test, this is going to tell you kind of where you fall in the risk pattern and how close attention you have to pay to it.
Welcome to the Wealthy, Wealthy, Wise podcast. If you would like to listen in on thought-provoking conversations with countercultural thought leaders and experts in the fields of wealth, health, and relationships, the 3 keys to having what I call a wealthy, wealthy life, then this is the show for you. I'm Krisstina Wise, real estate investor, best-selling author of Falling for Money, and founder of Wealthy Wealthy, where I serve as your personal guide to money, health, and happiness. Welcome back to Wealthy, Wealthy, Wise. In this episode, I talk to my good friend, Dr. Alan Hopkins. Alan is an ER doctor who is passionate about heart health. Why? Because he sees so many heart attacks in the ER. I learned from Alan that 1 in 5 Americans are genetically at high risk for having a heart attack, even those with a healthy lifestyle. He also talks how about conventional lab work from conventional doctors don't test for this gene that puts so many people at risk. Join in to learn more about how to optimize your heart health. And this isn't just for the men listening, it's for you too, ladies. Enjoy. Dr. Alan Hopkins. How are you? Thank you for being here today.
I am doing great. Thanks for having me. Always an honor.
Yeah, this is so much fun. I mean, obviously, I'm best friends with your wife, or she's one of my best friends, and I hope vice versa anyway. So we see you a lot, and so this is fun actually to be meeting in this type of format. And really, I have the honor through her of knowing you, and you educate me on so many things when it comes to medicine and anti-aging and unconventional medicine and so on and so forth. So I'm just now so excited that we get to introduce you to all of my listeners so they can benefit from knowing you as well.
Oh, that's great. I'm looking forward to chit-chatting with you a little bit.
All right. Well, you are a doctor, and I think we've established that already, but your focus, where you spend most of your time, is in the ER, correct?
Yeah, that's right. So, I've been practicing emergency medicine for the last 20 years or so. And when I turned 40, this is about 7 years ago, when I turned 40, I had this epiphany that I was getting older and that I was having trouble with maintaining muscle mass, and I was easier to, get belly fat, and, metabolism was slowing down. And I saw my friends and family. I just kind of wanted to learn more about preventative stuff, because I was taking care of people having a heart attack in their 40s. And I think the youngest person I've had a heart attack has been a 27-year-old guy. And that was from a real heart disease. So I became very interested in intervening early. And we do notice that teenagers, when we do autopsies on a teenager who maybe dies in a car accident, we'll see the plaque being laid down in their arteries on autopsy. So we know that plaque formation starts very early. And so the whole idea this epiphany is there something that could be done ahead of time to try to prevent that early event for people, and then to let them live not only a long life, but a long functional life. I mean, wouldn't it be great if we could actually go out and do stuff with our grandkids and travel the world and do all these things that we really want to do? And so that was where my focus was. Is not only it was a little bit selfish because I wanted to maintain my health and optimize it, but I also wanted to be able to help that and extend that to other people so they wouldn't have to come and see me in the ER.
Well, what a unique view that you are seeing that this occurrence happening over and over and over again, that all these people suffering from the same thing that wind up on your table, so to speak. And then with really, like you said, is there something we can do to prevent this? So in the ER, when you take out accidents, why do a majority of people come to the ER? Is there a consistent set of...
Yeah, well, I mean, I work at a trauma center, so we get a lot of the traumas in town, the gunshots and car accidents and those kind of things, because we have a 24-hour trauma team, on standby. They're actually in the hospital all the time. We're ready to operate on anybody. This is one of the hospitals that if the president comes into town, we cordon off 2 rooms the entire time he's within the vicinity of a helicopter ride to us. and his blood is typed and cross-matched in the blood bank and ready to go with secure phone lines to the White House. So this is what most trauma centers do. And so we see a lot of trauma in our hospital. And we do see some other things, the heart attacks and strokes and the falls and, all the sort of mishaps that occur, but you would not believe what happens to some people. And you literally see them at their worst. And so it's different every single day, and there's no consistency to it really, except that for right now we're having a little flu outbreak. Maybe you've heard about that, but we're seeing quite a bit of flu. But beyond that, it's very unpredictable, and that's what I love about it.
I bet. It's very much your personality. Well, I'm guessing you do, based on what you're saying, you do see a lot of heart attacks. So people they come in, and are they in the middle of a heart attack? How does a heart attack work?
Yeah, well, there's all sorts of different presentations for a heart attack. It could be in somebody who's young, who are having a little bit of chest pain, and you think that it's not a heart attack, and it ends up being a heart attack. It could be in somebody who was just standing there with their family, and suddenly they slumped over and their heart completely stopped, and maybe they got shocked and they got brought back, or maybe they did CPR en route. And so there's, it's a wide variety of people. What I did notice over 20 years of practicing was we used to see people in their 60s and 70s having these heart attacks. And so that was kind of like, that was the norm. That's what we expected. And nowadays we're seeing people in their 40s and 50s. And this is where the alarm bells started going off, because we were, like, hey, what is going on out there? Our technology is so much better. Why are we struggling with these early events? And that was my prime interest. I couldn't understand, at least being emergency medicine trained, I just didn't understand what in the world's going on out there. Where's the disconnect? So it really became a little bit of a passion for me to try to, help figure that out. And so it led me in a whole different direction into what I'm actually doing now. I still do emergency medicine, but also I'm in the preventative mode now too. So, and I'm very passionate about it.
So let's talk about our heart attacks. It sounds like this is a specialization of yours. You see a lot of cases and now you'd like to prevent them. And I think most of us still today, when we think of heart attacks, we hear the heart, we associate it with this word called cholesterol. And then if cholesterol gets high, then the GP will say, hey, let me give you a statin. And then that lowers the cholesterol. And that's about as much as we know about that, is preventative, let's say. So why don't you give us an education about the heart and about what you're looking for. And I think you even have mentioned to me, for example, that what's covered by insurance is certain type of panels that really don't even give us the metrics we need to see if we're at the highest risk for a heart attack. So would you talk me through all that?
Oh, yeah, sure. So, as you know, the heart is supplied by blood vessels. And if these blood vessels get clogged, like dirty plumbing, there's going to be a problem with flow. And when we get that problem with flow, we start having pains. If the blockage is large enough, we may not have any pain at all. We may actually just pass out, and we may just die. And so the whole idea is, how do we identify who has problems with hardening of the arteries early? So it really goes back decades when they began to look at cholesterol, and they identified it as a major risk factor for the development of this disease. Because when we cut open these arteries that supply the blood flow to the heart, we would see cholesterol plaques. And we would take these plaques, they look like yellow fat is really what it looks like within the artery itself. And we would notice that there were a bunch of cells in there. And then over time, the scientists sort of figured out that they were deposits of certain types of cholesterol, the bad cholesterol or lousy cholesterol. We call it LDL cholesterol. And so back in 1988, which is the year I graduated high school, by the way, great. The 80s were great. Loved it. Anyway, back in 1988 was the first consensus statement put out by the American College of Cardiology on what to do with cholesterol numbers. And so we began to lower them, statins, among other things. We'd lower the cholesterol. But the interesting thing is even though patients would get down to their goals, 50% of the heart attacks that now present to the emergency room are at goal. So something's not really working. There's still a disconnect. Like, why are we still having massive amounts of heart attacks, even though people have their cholesterol numbers brought down? So this leads some people to think, well, maybe cholesterol isn't that important. Maybe it isn't that thing that we need to worry about. Well, it turns out that scientists have been looking into this, and we've developed technology over the last couple decades to help us look even further into the cholesterol. So now I can tell you, look, you may have some good cholesterol, you may have some bad cholesterol, but now I can tell you all about the subunits or subclasses of your cholesterol. And if you have the small, dense kind of cholesterol, you're in trouble. If you have the light, fluffy kind, maybe the total cholesterol number isn't as important. So there's now advanced testing that can be done. And we've been fighting with insurance companies for the last several years and trying to get them to approve this testing. But they've been fighting us back, saying, look, we don't really think it matters. We don't really think it makes a difference. I think it's so funny that you have doctors who, are recommending these things at the highest levels. I mean, they do it in all the research. I mean, it's because they really want to know what's really working. So they do all this tests and the research, but then the insurance companies still don't think that it's important enough to pay for. So until we get more data down the line, will insurance companies realize that it is important.
So what would be the standard test you would get that would be covered by insurance, and how would you know that there are even other tests that you can, looking for other risk factors that you could test for, and then what do you do once you know about that?
Yeah, well, unfortunately, most people don't know. I mean, that's the short answer. Unless you're actually looking out there, researching and trying to find the information, most people don't know. So let's talk a little bit about what your doctor does pretty much every year when you go in for a physical. They ask you to fast. They don't want you to eat or drink anything after midnight. You come in and they're going to measure something called a fasting lipid panel. This simply measures your total cholesterol, and it measures your HDL or good cholesterol, your LDL or lousy cholesterol, and that's just a calculation. It actually isn't a measurement. It's just a mathematical calculation, which is not terribly accurate at lower levels. And then they tell you what your triglycerides are. That's a standard fasting lipid panel. It's something that pretty much is run on everybody when they go in to see their doctor for their annual exam. The tests that I'm talking about are called advanced lipid panels. This is where we're actually looking at numerous additional biomarkers that we could get into, but essentially what we want to know is what type of a pattern are you? Are you a good pattern, somebody that has the light, fluffy kind, or are you a bad pattern? So the way I tell the story, and I like to tell this analogy because people tend to remember this. So let's just say you have lousy cholesterol. So you went to your doctor and your doctor said, yeah, your cholesterol is kind of high. And it turns out a lot of it is the LDL cholesterol. And so you're smart enough, you're like, ooh, LDL, that sounds bad to me. Do I need to worry about this? Well, if you did the advanced cholesterol testing, it would be like this. Okay, so you have 4 boys. Okay, I'm just making this up. It's just an analogy. Okay, your 4 boys are going to be the 4 different types of LDL cholesterol that we have. Kid number 1 goes to school. He makes straight A's. You never have to worry about him. You're constantly just happy. You come home and he's, washed your car and giving you a massage. That may be weird, but I mean, he's just a good kid, right? I mean, just a good kid. Kid number 2, this kid, he does pretty well. He A's and B's, and maybe he's made a C every now and then. Maybe you've given him a swat on the bottom, once or twice. He's just a good kid. You're pretty proud of him. All right, boy number 3, this kid's an embarrassment. I mean, he's been stealing gum since he was a little kid, and then he stole bicycles, and then when he became a teenager, he got the neighbor girl pregnant, and then 2 weeks later, you find out he got the neighbor girl's mom pregnant. He's in and out of the hospital with fights and jail, and you can't sleep. He's stressing you out all the time because you never know what's going to happen. Kid number 4 rapes and kills people. All right, so what I've just described to you is what the types of LDL patterns you can have. So you can either have the small, dangerous pattern, which is kids 3 and 4, or you can have the light, fluffy kind, which are kids 1 and 2. So wouldn't that be nice for you to know which type you have? Pattern B is the bad type. Pattern A is the good type. So this test will tell you whether or not you have the kids that are good, that aren't going to tend to cause disease, or it's going to tell you if you have the dangerous ones, the pattern B, the ones that are going to cause disease. So that's helpful. So why is it helpful? Because there are things you can do right now to change the makeup of your cholesterol. And we can talk more about that. But that's the advantage of advanced cholesterol tests. You never find out that information on a fasting lipid test. So you may not know that you need to fix something. You may just know, oh, it's a little bit high, and my doctor told me to watch what I eat. Well, there's kind of a problem with that. 70% of the way that we process cholesterol is genetically determined. So that means that even in the best cases where we're eating very, very good, eating healthy fats and skipping all the French fries and the potato chips and so on, we can still only move our cholesterol by about 25 to 30% at most. So we're never going to lower it by half just through nutrition. And so it's really important to know that a lot of times you measure your cholesterol and maybe your doctor told you it was high and you need to watch what you eat. But there's more to the story beyond that. A lot of it's genetic. And no matter how good you eat, you still may be in trouble. So I always like for people to get a baseline advanced lipid test done just so they can know where they stand. And then if they want to do maximum nutrition intervention, maybe add some nutraceuticals. Omega-3 fish oil is a great example of a nutraceutical for people to take because it can convert you from a pattern B to a pattern A. It can increase your good cholesterol, your HDL. It can increase that higher. And it can also lower your triglycerides. So it's one of the big bang for the buck nutraceuticals that you might want to be on if you find out that you have these cholesterol issues and eat healthy, right? And so instead of running for just a statin, I would probably just look at the advanced cholesterol panel and then get as much information as you can and then try to change things as naturally as you can. I like statins in some people that are very high risk, but they do increase the risk for diabetes. There's some association with dementia. And so it's not just sort of snap, bam, take a statin, particularly in women. Women are a little bit higher risk for development of dementia and those type of things. So I don't like to just jump towards that. I like to have a full picture. An advanced cholesterol panel helps you do that. The other thing in the advanced cholesterol panel that I really love to tell people about is Lipoprotein-A. You can get this test done individually without the vast lipid panel, but you might as well just get it done as part of the panel because it is included. Lipoprotein-A, do you know what it is? Have you ever heard of it? No? Okay. So it is a genetic variant of the LDL cholesterol. It's the smallest, densest cholesterol particle there is. And it's genetically inherited. It changes, it does not change at all with nutrition intervention. So you can't change it at all. And you got it from your parents. So if you have heart disease in your family, if your father had heart problems and grandpa did or grandma did, chances are you guys inherited the lipoprotein-A variant, meaning that you have the smallest, most dense particle. Do you have any idea of how many people have it here in the U.S.? No. 73 million people have it. That's 1 in every 5 people have it here in the U.S. on average. And nobody knows about it. So maybe this is the reason where 50% of the heart attacks come into the hospital and their LDL, at least fasted lipid panel, looks normal. Nobody ever checked a lipoprotein-A on them. It wasn't covered by insurance. The doctors didn't know anything about it because they never learned about it in school because it wasn't covered by insurance because they were taught they couldn't order it. So it's never ordered, never really educated the physicians. And so now it's sort of, you're just suffering the consequences of it. And so what's interesting is in Africa, the penetrance is a little bit higher. So it's about 30% of people have it. And so if you look at the migratory patterns of people over the ages, you can kind of see the breakdown. But here in the US and really South America, it's about 20% of us have it. I could tell you my wife has it. Her father has it. Probably her father's, one of the parents probably had it because it's genetically inherited. So it's going to be important that when my kids get into their 20s, I'm going to have them checked because my wife inherited a little bit. But if my son inherits it a lot, then that's going to be concerning. If you're in the top third quartile or top third of the measurement for Lp(a), your risk for heart attack goes up threefold. So that's even just being in the top. So if you have high lipoprotein-A, you've got to do everything you can to lower all your other risks, like inflammation, diabetes, insulin resistance, all these things that can contribute to hardening the arteries. And if you're a smoker, boy, that's no better reason to quit smoking than to know you have inherited this extremely dangerous particle.
So let me ask you this very quick.
Yes.
So when people test for the lipoprotein-A, and it's a genetic mutation where the LDL is, explain that again, where...
So you have an LDL particle. It's really small. It's really dense. Well, in this genetic variant, there's a chain of about 50 amino acids attached to this LDL molecule on the outside. It's called a Kringle particle. Okay? A Kringle. It just kind of sounds funny. But yeah, I think about Pringles. It makes me think about Kringle.
Kris Kringle.
But it has this little thing called a Kringle particle, and it makes it extremely atherogenic, meaning it's extremely disease-causing. I have somebody your age in my practice, and great shape, just like you are. Actually looks very similar to you. But all of her biomarkers, over 100 of them that we checked, were completely normal. She had already had a heart attack. Okay, I'm telling you, no inflammation, no insulin resistance, everything else looked awesome, but her lipoprotein-A was markedly elevated. And she said to me, "Doctor, do you know why I had the heart attack?" And I said, "Yes, I do." I said, "You have this really high lipoprotein-A." And she said, "I was wondering if it could be genetic because my father passed away when he was very young." So if you have anyone in your family that's had early, stroke or heart attack, or you yourself are just concerned because, quite honestly, 20% is a pretty high percentage, I would get it checked. And then if you're high, there are different treatment options that I do discuss, and I'll be happy to share that with your listeners on a follow-up content for them if they want. But it can be treated. I think the biggest thing is that I want to push out there is we just got to know about it. We just got to look for it. We got to make our doctors read about it. We've got to really push them to make sure that we're not going to be one of those people. And also for our children. I mean, I don't want my kids, dying young because of something that I just didn't know about. So they're going to get screened because it's in my family. One of my nurses has it. She is also 45 or so, and she already has a lesion on her left anterior descending artery. And we picked it up this year because her mom came in to get tested, and she had it. And she had had a heart attack when she was 50 years old, or 55, I think. So the whole idea is that, it's there, and people are just missing it. And so I'm just here to tell you, you don't need to miss it. Okay, well, exactly. So again, just for clarity reasons, if I get my advanced lipid panel and I'm looking at the lipoprotein-A, is the lipoprotein-A is what you're looking for? Like everyone has, the part of the biomarker is just the number associated with that. Meaning, if it started at 0, there's no risk, and if I'm making a number, but 100 means high risk. But you're getting tested for that just to see where you are on the range. That's right. Everybody tends to make a little bit of lipoprotein-A. To give you an example, I think my number was somewhere around 25 or 30, and my wife's was like 128, something like that. Well, less than 75 is where you want to be, at least on the laboratories that we do. So we put out an absolute number and then a range of where you should be and what is optimal, what's borderline, and what's high risk. The idea is if you fall within the high risk zone, you want to do everything you can to control everything else, because remember, this is genetic. It doesn't change with nutrition. So most of the treatments are actually very natural. B vitamins, niacin in very high doses is how we treat it. Oftentimes we'll put people on a baby aspirin every day just to try to reduce the risk of stickiness because we assume they already have plaque formation. Some of my patients, I'll send them for a calcium CT score. It's a $99 test. You go to the CAT scan down here in Austin, and we look at your arteries and see if we already see lesions developing. You would be surprised at what we find, because it really starts in our teenage years when we begin to lay down plaque, and it's really, we're eating horribly these days. We're laying it down earlier than we've ever seen before. But the idea is if you have this genetic variant, you're going to be much worse. If you smoke and have this genetic variant, you're in real trouble. If you have diabetes and you have this genetic variant, that's very bad. So control your diabetes. If you have insulin resistance syndrome or inflammation, you need to get rid of that. So the whole idea with prevention is that we know there's a problem, and we do everything we can to fix everything around it that contributes to it. When you say variant, what is the variant? Is it over 75? Meaning most people would say be under this number that has been established. So the variant is, okay, it's, let's say, quote unquote, normal under this amount, but if it's over the 75, that moves into a different risk category because the lipoproteins are more and more condensed or whatever that is happening, then that is what is the variant, right? Right. Yeah. So the genetic variant is the 50 chain amino acids that are hooked to the LDL molecule. Most people maybe have just a few of these particles around, but for example, my wife has a lot of the particles around, and I don't have very many. Her father had a lot. When I say it it's inherited differently. My children might have a ton of particles, or they might have had just a little bit. And it sort of depends. I mean, you can have the genetic marker for it, but not be quite as sick as somebody else. Your number may not be as high.
Based on how high the number is.
Right. So when I tell you 73 million, that's 73 million people have high risk, meaning they're not optimal, they're not borderline, they're high risk. So I can tell you, if I test 5 people here, one of those people will likely have the genetic variant that puts them at high risk. And so just if they know that, then they can go to their doctor and say, look, I got this test. I'm concerned about it. I've done some reading on it. This is what I know. And it forces your primary care doctor, your cardiologist, whoever it is, to actually address it with you and follow it over the years, instead of you just coming up with your surprise heart attack at age 50.
So where before more conventional means, insurance covered means, your cholesterol is over 200. So maybe you need a statin or need to change a few lifestyle factors. What you're saying is, okay, the fasting cholesterol, yes, that gives some of these numbers, but we need to go a little bit deeper and look a little bit closer. Because one, even if that's lower, like a lower number that otherwise would be in the ideal category, if you test for these high lipoproteins, then we have a genetic issue that isn't going to show up on the other test. And anything over 75, we're probably going to look at some lifestyle changes. And over X, we're going to put you in the high risk category.
Yeah. On our test, it's over 125. You go into the high risk category, which just means that we have to look at you as a whole and do everything we can to keep blood pressure low. We've got to make sure you don't have inflammation. So we'll actually look at CRP levels. That's an inflammatory marker. Make sure you don't have chronic inflammation. And then we've got to look at the nutrition. I mean, we got to lower your LDL cholesterol. We know we can do it through nutrition. We can't lower your Lp(a) through nutrition. We might try high dose niacin with you if you can handle the flushing. That actually works to keep it down. And then a baby aspirin. And we might do other natural things like omega-3s and CoQ10, to increase your amount of good cholesterol that pulls that Lp(a) out of the lining of the arteries. There's a lot of little treatment strategies that are very natural that can be done. And statins can be used too if we need to use them. I'm just a proponent of knowledge, because knowledge is power. And if we do more research on lipoprotein-A, on natural treatments for it, we're all going to benefit from that. But they're not going to do research unless we push them through knowledge. I mean, if they're, I swear, if 73 million people got tested and they all went to the doctor at once and they said, what's going on? This has got to get fixed. Well, somebody would put a little bit more effort into fixing it. Right now, doctors typically don't know about the test. Insurance doesn't cover it, and they don't get tested. And this is not an expensive test to get done. It really isn't. You can get a whole advanced lipid panel for $175. I mean, this is not an extremely expensive test. And I recommend it for all my patients at least one time a year, at least one time in their life. And then if they have a problem with it, I recommend it rechecked one time a year.
So if you're in the high risk factor, one, when you get your annual test, make sure you ask your doctor for the advanced lipid panel. When they say, I don't know what that is, what do you say then?
Oh my goodness, no. So, what I recommend for people to do that aren't seeing me is to actually go in there armed with some information about it. And so there is plenty of information out there on the web if you can find reputable sources. I will give you some information so that your people have the latest information and they can talk very eloquently about this with their physicians. We do encourage people to follow up, and particularly if they have other conditions, particularly diabetes and so on, they're pretty high risk anyway. But that's really the reason why. I mean, that in diabetes, you can actually change the way that you make your cholesterol molecules. You make them smaller and denser. And this is why we see.
All right. Well, Alan, welcome back. We had a few technical glitches there. So I think you were saying when we dropped off that if you test for lipoprotein-A and it looks like you are at a higher or high risk, that it's even especially important that if you have some other maybe lifestyle diseases like diabetes or lifestyle choices like smoking, it makes it that much worse. And that especially diabetes, for example, even changes the structure of your cells. So do you want to jump back on?
Yeah, sure.
That stream of thought?
Yeah, sure. The whole idea is we're trying to prevent the hardening of the arteries. And this just happens as we age. I mean, everybody's going to get hardening the arteries. We haven't figured out a way to completely stop it. But we know that certain things cause hardening the arteries. Lipoprotein is just one of them, and it's just a very dangerous particle because, number one, nobody knows about it, nobody gets checked for it, and so there's people walking around who are, in perfect, ideal body mass index. They're not overweight at all. They've got a good lifestyle. They're maybe a jogger. They do all these things great, and then all of a sudden they keel over and die, and they never had their LP(a) checked. And it turns out, when we look into their family history, we find out, grandpa had the same issue, but, we kind of thought it was because he smoked. His grandpa had the same issue, but we kind of thought it was because he was overweight. Well, the reality of it is that in order to prevent hardening the arteries, we just want to know. And so I tell all my patients that have very high risk lipoprotein(a), I say, now it's time to invest in your health, because you are high risk. We need to do a comprehensive analysis of your biomarkers, and let's look for other things that are going to lead to hardening the arteries. And let's try to fix those things, because I can't fix your genetics. Your genetics are what they are. If we try real high dose niacin, we might be able to get that down if you can tolerate the niacin. But the truth is, most people struggle with niacin because it causes flushing. And unfortunately, the non-flushing kind doesn't work to lower lipoprotein(a) because of the inositol it has in it. It's just ineffective. So you have to use the flushing kind. You can get it over the counter. It's called slow niacin. You can get it from your doctor. It's called Niaspan. It's the same thing. It's high dose B vitamin. That's really the only thing that's been shown to really dramatically lower lipoprotein(a). So we have to look outside of that lipoprotein(a), and we have to think about other things you might have that we'll uncover from additional biomarker testing. One of the things I mentioned earlier was chronic inflammation, as evidenced by elevations of your CRP. We also could be looking for insulin resistance or prediabetes or diabetes. We know that those states will change your cholesterol patterns and make you from light and fluffy to small and dangerous on your molecules. So we like to know about it, because if we fix prediabetes and we completely reverse it, we can actually reverse your cholesterol shape and make it more light and buoyant, less disease causing. And wouldn't that be great? Because you already have LP(a). So we're really looking for other things. So again, I tell my patients, now's the time to put your health first. If you haven't already done so, let's stop smoking. Let's get your blood pressure down to where it's quite low. There's pre-hypertension now, just like we have pre-diabetes, we have pre-hypertension. So we like to keep the blood pressure less than 120/70 for people that have these increased risk. So the whole idea is, you eat better, you exercise more, and you get additional testing done to know where you can also make very natural changes to support the next few decades of your life and work to reverse the plaque that's likely already formed in your arteries. And again, for those patients who are a little bit further along in life, I'll oftentimes get a coronary CAT scan, which is just a CT scan, not real expensive thing. And we will actually be able to look at the arteries around the heart and see if there's deposits of plaque already. And if there are, well, that's an additional motivator. I'm a physician, so I love data. Because data helps me make decisions. And I found out that patients that are truly enrolled with their health, they like data too, because they're actually able to see how they can manipulate these numbers through their, by paying attention to them. So the choice is put your head in the sand and, we don't have any technology to help you. That's kind of, that's one way to do it. Or, you know what, you have it. Let's go ahead and do full bore and do everything we can to protect you as you age.
Yeah. And there's a couple things there that I think of is one, maybe I've not had the healthiest lifestyle. And then I'm already on the edge of probably having some under just the fasting cholesterol panel that already those numbers are high. I don't even know about lipoprotein(a). So, but I'm thinking, I'll just take my chances or maybe watch it. But the danger there, if you don't know about lipoprotein(a), that if compared to someone that has low lipoprotein(a) with the same lifestyle are far lower risk. So by not knowing about this, that you may be more inclined to make changes if you know that you're actually at a much higher risk if you have this genetic factor. Is that correct?
It's like stepping on a scale. If I look down at the scale and I see a number I don't like, sometimes that encourages me to get on it, and I need to start eating better and start running or doing some exercise. I need to start losing weight. So just like a scale can be an aid for you, this also can be an aid because it's an absolute number. It's your number. It's nobody else's. And it's very specific to you and your family. And if you have an elevated number, it not only helps you to know about it, it's going to help your offspring. And guess what? Aunts and uncles and other people in your family, if you have it, chances are maybe they have it too, so they just need to get checked. And then by helping yourself, you could potentially help numerous people around you in your family, because this is a family thing. I mean, people are going to have it. You will find it in the family. It's just depending on who is it going to be. So, but yeah, no, it's an absolute number. It's very specific to a person. And so that's why I think it really helps to know about it. And it forces that person to at least take action of learning. There's no excuse for us not to know now, because we have the internet. We can Google things. We can look it up. We can find reliable sources online. We can find experts that know a lot about this. There's people out there that are writing books on this. So this is some knowledge is power. So the whole idea is we want to empower people to take control of their health, because I'm just suggesting that your primary care doctor is probably not doing this for you. Now, if there are primary care doctors out there doing it, that's amazing, and I'm sure there are. I'm just telling you that many of these 73 million people that have this here in the United States do not even know it.
Right, and I think what I was trying to say is that if two people that has one of the 73 million that has this genetic variant, the same person compared to the same person who doesn't, with the same lifestyle that's on the edge of not so healthy, those that have that same not so healthy lifestyle combined with the Lipoprotein-A variant are at probably very high risk of heart attack.
Yeah, absolutely. That's the whole idea, is that you may have two people that are at risk, but what you want to do is lower the chances of an event by fixing all the things that you can fix. Even if you can't get the lipoprotein absolute number down, which is possible. There are treatments for it, but they are difficult. But anyway, that's kind of the story. I mean, if you've ever seen anybody or heard about, I'm sure you have in your life, oh man, they died of a heart attack? What? I don't understand. They ran all the time. They were in great shape. They didn't seem to be stressed out. They seemed to be, well, there you go. That was probably lipoprotein-A. Can't prove that in everybody that dies young, but I'm telling you, it's a huge contributor that we don't know about.
And I think that was the second thing I was going to mention, is that someone like your wife who looks perfect. I mean, she's gorgeous and she exercises all the time and she has a very healthy diet, and she would never in a million years think she might have any heart issues or be at risk for a heart attack, I'm guessing. So there's a lot of us out there, to your point, that we're thinking, oh, I may die of something. But the last thing it would be a heart attack.
Right.
And what you're saying is, oh no, I see people just like you, Krisstina, dying all the time in my ER, and come to find out it's because they have this genetic condition that has nothing to do with lifestyle, or little to do, because it's all genetic.
Yeah, I would say that there's only one caveat to what you're saying.
Okay.
The caveat is, I see people dying from heart attacks all the time, but they're extremely unhealthy.
I mean the healthy one,
yeah,
yes.
Every now and then we do have a healthy person where we all wonder why, and we're just missing that lipoprotein-A. But I think the major contributor right now is just we're all eating too much sugar. We're eating horribly. We're not exercising. We're walking around with chronic inflammation. We're exposed to all these toxins in our environment. We've got all these autoimmune diseases. I mean, there's a lot of just in general problems out there, not to mention this lipoprotein-A. So the whole idea behind lipoprotein-A is it's kind of that little thing that can maybe pique somebody's interest to where they begin to look into their health and to take action. Because at the end of the day, it's not so much about knowing as it is about taking action. And so, once you know, then you can start to take action. And that's where that's what you want to do. And that's what stepping on a scale does for people. They see the absolute number and they want to take action. Same thing with any biomarker.
So as we're wrapping up and coming to the end of our time together, people get their annual exams, they get their fasting cholesterol panel. And let's say that I want to get in, maybe my doctor doesn't necessarily agree with this advanced lipid panel and or just won't test it. Can I get it on my own?
Yeah, absolutely. You can get it on your own. And where I was saying was the $175 is it's a thing called yourlabwork.com. And you could put out the URL for people, but yourlabwork.com has this module. It's called the Heart Healthy module or Advanced Cholesterol Panel. And that is what includes the Lipoprotein-A, and it looks at what pattern type you have. Remember the kids, do you have good kids or bad kids? And we'll also tell you whether you have the best kind of good cholesterol. We didn't really touch on that. HDL is a good cholesterol. That's what tends to go up as we lose weight and we stop smoking and we exercise and we take omega-3 fish oil. All those things could increase the good, large cholesterol. The more large good cholesterol we have, the better, because that's really efficient at bringing down your lipoprotein-A and your LDL molecules. But it shows you kind of all those things, and it also includes the fasting lipid panel numbers in it. So you're not missing out on those at all. You're getting kind of the whole shebang right there. But yeah, no, I do recommend that people just go and get it done. I mean, there is no barrier to access here. It's $175 on that particular website, very inexpensive, and you just get it checked once in your life. And if you're okay, and that's fantastic, and everybody's going to congratulate you. And if you're not okay, then maybe you can start looking for some solutions. And the idea is that right now we just don't know, and I just don't think it's being checked. And I know the insurance companies aren't covering it, and it's something that's killing people.
And so with your lovely wife that has this genetic variant, what is her lifestyle choices? Do you put her on statins, or what is she doing to lower the risk?
Yeah, so fortunately for her, all her other numbers look fantastic, as you might imagine, from her lifestyle. Her triglycerides are very, very low. Her LDL particle number is very, very low. Her HDL, the good cholesterol, is very high because she exercises all the time. But for her, for example, one of the things that can help her is taking omega-3 fish oil. Very natural. We did put her on that. CoQ10 has been shown to lower the lipoprotein-A a little bit, so we put her on CoQ10 as well. So I put her on 3,000 milligrams of fish oil a day and 200 milligrams of CoQ10. There's no reason to put her on a statin. She has no inflammation, and all her other risk factors are controlled. And of course, she's not a smoker. Now, I have another patient who I talked to 2 days ago who has the exact opposite picture. His Lp(a) is about 50 or 60 points higher than my wife's. His particle number is through the roof, meaning he's got a ton of LDL particles. He's got pattern B. By the way, my wife had pattern A. She had the good kids, which is in line with our kids. But anyway, this guy had pattern B. So in addition to the lipoprotein-A, he also had the most dangerous LDL particles. And he also had inflammation. And so he's somebody who actually would benefit from going on a statin therapy to lower that LDL particle number and lower that LDL very low. Again, high dose omega-3 for him. Omega-3s reduce inflammation. They increase HDL, and they decrease triglycerides, and they'll help convert him from a pattern B to a pattern A. And then he can also do CoQ10 as well, a couple hundred milligrams of CoQ10 and a baby aspirin. That's kind of where we start, and we just see if we can also get him to eat better and lose weight. He's also overweight, and he needs to lose some weight, and he has some insulin resistance that needs to be reversed. So there's much more complicated approach for him because he's much, much sicker. And so my wife's a little bit easy because she has no other complicating matters. So it's just a matter of how low can we get this naturally. And if she can tolerate high-dose niacin, then she might be able to get it to completely normal to where it's in the optimal range. So that's kind of the idea with it.
And so with your other patient, now if he changed some lifestyle factors, started eating better, started exercising, and reduced some inflammation, some stress, some other factors in his life that lead to the inflammation, and he starts taking the fish oil and maybe the niacin and some of these other more natural means of trying to lower the risk, is there a point where he could get off the statins? In this case?
Yeah, I mean, maybe so. The problem with him is genetically, he inherited a tendency to make way too much cholesterol. So his cholesterol absolute number was around 300 total cholesterol, very high. An ideal number is 150, which my wife's was 148, by the way. So for him, it's much more likely that he's going to have to be on long-term therapy. And what'll be interesting to see is he's able to tolerate niacin as well to get down his LP little a. He's actually very sick. He's one of these guys that without intervention would die young. And what we're trying to do now is wait on his calcium CT scoring and then see if we can reverse the plaque. So we'll recheck him in a period of 3 to 4 months with another advanced cholesterol panel. We'll see how low we got him, and we'll see how high we get his good cholesterol. We'll see how he's doing with the very difficult thing, which is changing the lifestyle, exercising more and making eating a priority. Do you eat well? So we'll do those things, and we'll just see how he does. I did have an actual physician who came to see me, and he had a decreased blood flow to his leg, and he had an angioplasty done to his iliac artery, and he's 48 years old. I mean, that's young to have this bad peripheral vascular disease. And he had similar cholesterol pattern, horrible, and we worked on him really good for 3 months, did some things, and he made a remarkable turnaround in terms of all his absolute numbers. So in my mind, I think for him, the nice benefit is going to be that he will reverse some of that atherosclerosis. You can reverse it if you can really get that HDL up high enough. You can reverse that disease process. And that's really want to get the point across is this is not all gloom and doom and, oh my God, I have this and there's nothing that can be done. There's actually a lot that can be done if you know about it. And that's why we test for it. And that's why I'm out here talking about it, because I want you to go and get tested. Don't wait around for your doctor to do it. Do it yourself. You can do it, easy to get to. And man, it'd be awesome to find out if you're in the clear or if you have some issues you have to deal with, like anything else. I do have patients that never want to get on the scale. No matter what I tell them, they don't want to get on the scale. They don't want to see the number. In this particular case, there's no harm in seeing the number. It's good to know about it because there will only be good benefits, even if it's a conversation with your primary care doctor about, hey, what does this number mean? Even if you don't want to do anything else, but take it in and show, what does this number mean? And force that doctor to either do research about it or to tell you everything they know about it and how they're going to monitor it over the next several years. So that's the point I want to get across.
Well, great. Well, a couple other questions when you're talking about just clarification for the layman questions. When you're talking about LDL, like LDL and HDL, obviously we've heard these things. Low LDL is bad and high LDL is good, and you want to be around the 150 mark, and sort of these known metrics without really knowing what they mean or why they're good or bad. So is LD bad because they are these small, dense particles that are more likely to lay down as plaque as opposed to the HDL, which the light, fluffy ones are likely just to move through the bloodstream and do the good work they're supposed to do?
Yeah, so here's my story on this. These molecules in themselves are not bad. I mean, they're meant in our body to transport cholesterol and triglycerides in varying amounts. That's what they do, and we totally love them for that. The problem is that some people genetically make too much of the LDL or lousy type, and they don't make enough of the HDL or happy type. And so with an imbalance, you get a problem because we know that HDL is the transporter for LDL. It actually removes it and recycles and takes it back to the liver. All these cholesterol molecules are born in the liver. The liver makes them and pumps them out. HDL is like the police, and then LDL is like the robbers. The robbers go out and they try to hide and infiltrate into the neighborhood. The police are searching for them and they're pulling them right back out. Now, the advanced cholesterol panel tells us what kind of robbers are we dealing with? Are we dealing with sort of just petty thieves that we don't really care about? Or are we dealing with murderers? If we're dealing with murderers, we need to have the best cops possible. We need to call in the Delta force of cops, right? And that's where the good large HDL molecules come from, the big guys. So we call in our big guys to get rid of these rapists and murderers. The petty thieves, if you have petty thieves, which are the light, fluffy LDL molecules, they're not so bad. But if you have the small, dense LDL, or the horrible people, the horrible robbers that rape and kill people, we need the best that we can to. It's all about a balance. You see, if you don't have a balance, you're going to lay down plaque. That's the simplest way to look at it. HDL, it removes it. They're the police. LDL, they're the people that they shouldn't be, the bad guys, right? But in the end, the truth is they're both very good for us. We need them to live, and they make cholesterol makes all our hormones. So it's important to have cholesterol. So cholesterol in and of itself is not bad. It's actually very necessary and very important for us. It's just that some of us are out of balance, and a lot of it has to relate to genetics and the way that we eat. So if we understand that we can affect it by the way that we eat, that's fantastic. But now we have even better testing where we can look and we can see, what our situation was and what we got handed to us genetically. just like you would go and you would take any other genetic test. This is going to tell you kind of where you fall in the risk pattern and how close attention you have to pay to it.
Well, great. Well, you talked me into this. And so I just recently did my high lipid panel and my advanced lipid panel with you. And I don't know if you've looked at it yet, but I'm really curious to see where I wound up, if I have this genetic variant or not.
Yeah. Well, I don't recall seeing it, but I'm happy to go over those results with you. I think it is interesting for people to look at. And what I've done in the last week or so, because I kind of got into this, is I actually made a Zoom cast where I actually spend 10 minutes talking about the whole advanced lipid panel, maybe about 5 or 6 minutes talking about Lp(a). So I'll send that to you as a URL. It's just a link that you could put in, and then people could go to it and just watch it, and they can learn about this more deeply. I know it's really hard to take in just on a one-time deal, but when you actually get a chance to get the testing done, and it's your numbers, and you're sitting down listening to the screencast, it'll make it much more clear for you on where you're at.
Well, that's great. And you're speaking at an event I'm holding next week. So maybe we can go through that and we'll record it for the listeners also, that you can show my labs and give an explanation, and you'll teach me and teach everyone listening at the same time.
Oh, yeah. Yeah, I would love to do that. I think that's a great way to do it, is we'll get your labs. We can de-identify you if you want, or we can just put your picture right above your labs, and then we can go through them.
Yeah, you can just to show the world like how healthy I really am, healthy or unhealthy. We'll put it all out there. Well, that's great. One question, we'll wrap this up. One question that I ask all my listeners is about myths. I'd like to do a little myth busting. Sure. So just really based on your work, maybe a lot of what you see in the ER, obviously I think you've done a lot of busting here about what we've been talking about, but is there any conventional wisdom out there that you see repeated or told or spoken that you just know isn't true? I would like to bust that.
Well, I think sort of the biggest number that stuck out to me when I was doing all the research on this was that 50% of people who come into the ER have cholesterol numbers that are at goal and are still having a heart attack. And so why is that? And, most people would think that if you control just your fasting lipid panel numbers, you're going to be okay. But the absolute truth is that we just didn't know that what everything, the underlying mechanisms that were going on. The advanced lipid panel really helps us understand that. So the biggest myth would probably be that your cholesterol is fine. You're going to be fine. You're in great shape. You're going to be fine. And this is kind of like one of these sudden death things that, if your LP number was, 300, 400 and you're totally normal and everything else, that's still a big time problem. That's a huge problem, and you can drop dead from that. And wouldn't it be nice to know and be really aggressive about treating it early on in your life and not let decades of plaque develop way prematurely? So that's probably my biggest myth. I could probably think of a few others, but that's probably one of them.
Well, that's good. One final thing when it comes to labs and stepping on the scale, if you will, and we've been talking about this one specific biomarker. Labs in general, again, to use the example, you go in, you're getting your annual physical and some blood work that goes along with that. How incomplete is that? Like, what else besides, if anything, besides the advanced lipid panel, do you recommend people do at least once a year?
Yeah,
or at least once.
Yeah, at least once. Well, I'm a big believer in fasting insulin getting checked along with, your glucose and A1C. Glucose and A1C may usually be checked. Usually they do check a glucose. The A1C is the 3-month measurement of the sugar. But before those elevate and cause problems, we usually see really high levels of insulin. It's called insulin resistance syndrome. It's the very earliest thing we see on the road to diabetes, and it's not commonly checked. Nobody really seems to know about it. So the whole idea is if we identify you have insulin resistance syndrome, we can really help you lose weight, because if your insulin's high, it's a fat fertilizer. It helps you keep that fat on. So I really try to get people to get that checked. I think that's really important. Inflammation, they never really check for that. I like to know if my patients have chronic inflammation. I've picked up cancer that way, because the CRP levels will be very, very high. It's very high with autoimmune diseases. But if it stays high for a period of time, over 3 months, we got to start digging and figuring out why it's high, because the higher the inflammation is, and this is particularly true in females, the higher the inflammation is, the higher the risk for autoimmune diseases like Crohn's and ulcerative colitis and lupus and Graves' disease and Hashimoto's, the thyroid problems. The higher your CRP is, the higher your risk for autoimmune diseases are. Similarly, the higher your risk for cancer. So if you have chronic inflammation, that needs to be reversed. So those are sort of my big things, like fasting lipid panel. I like for people to get the insulin checked, and I also like to make sure that they don't have, chronic inflammation. There are nutrient deficiencies that you can check. I like to check the omega-6 index. Most of us are not taking in enough omega-3s. We're quite deficient in them. It's just sort of our diet these days. And I just told you in this whole thing how great omega-3s were. And actually, in my wife, it's funny because we did test that with her and it was low. And, she had forgot that she had, because she'd been taking them, but she forgot that's the one thing that she ran out of that she never replaced. And I explained to her, look, what it will do in her system to help her with the Lp(a). So omega-3s are awesome. And you can actually check and see where you're at on your index. And that will help guide whether you need to take more or back off a little bit. The problem with omega-3s, if you take way too much, they can make you bleed a little bit easier. So the idea is to try to find out if you're in that optimal range of omega-3s. Doctors don't typically check for that. Vitamin D, sometimes they'll check for that if you ask for it. B12, they might. Folate, they might. But there's a lot of nutrients. Iron deficiency, very common in women. About 35% of all women will have iron deficiency. So those are all things you can get checked on your own too, by the way. That's the greatest thing about it now, is that you can go literally to a website and put in whatever order you want, and the results will be sent to you after they're drawn. So it's a nice thing. We don't have to wait necessarily on our primary care doctor to do it. Now we can have the data. We can look it up and figure out kind of what questions we want to ask about it. And then we can go in and see our doctor, present our case to him. I think the more interest you have in your health, the better you're going to do. And I'm sure you say that in finances, right? You can't just close your eyes and hope somebody else is going to make you a bunch of money. The whole idea is that the more you know about your situation, the more actively involved you're going to be, the better outcome you're going to have. And it's the same thing in medicine as it is with finances. You're probably the best person who's going to know about, how you want to manage your finances. Same thing with your health.
Well, and as you said, knowledge is power in this case. So if we don't know, we can't do anything. And once we do know, then we have choices that we can make changes or not make changes, but then it's up to us. But it's just walking around without knowing that we're close to a heart attack. We have this inflammation and just, weeks away or months away from some autoimmune disease, or we can't get rid of the weight because we have high insulin resistance and we're just not aware. With the knowing, just a few changes actually can make a big difference. So what I think, bottom line, I get my labs tested. I get my labs tested through y'all's labs, and it's very affordable, relatively speaking, probably far more affordable than trying to go to your doctor to get it. And to your point there, we can really access the knowledge these days. It's up to us. But we have to care beyond what our insurance is going to cover.
Yeah, I try not to, unfortunately these days, most people are having to pay out of pocket for pretty much everything. Deductibles since 2014 have been shooting through the roof, and less co-insurance for labs. They used to pay for 70% of your labs. Now, even if it is covered, they only pay for 50% for most people. So the lab costs are exorbitant. And so part of my passion for getting people checked was, hey, is it possible for us to get national contracts and a national ability to lay a company out there where people can actually go and directly access the tests that they want on their own terms. And that allows them to own their health, and it gives them some empowerment. And so the yourlabwork.com, which is a website that I work with, is sort of the culmination of all that. We've really made it possible. We operate in 46 states. You can go and you can get your labs tested at any point. And of course, we always want you to, because we think it makes you the best advocate for yourself.
Well, that's great. We will make sure to put a link in the show notes. We'll probably put a little coupon in there or something to make it, and really encourage everyone to get their lab work, step on the scale, and to be interested. I mean, part of my goal with these podcasts is really just to create awareness and interest. Like, wow, I never even knew I could get my own labs. I never knew there's such things as advanced lipid panel. Wow, I never would have known that I may be at risk for heart disease when otherwise I think I'm pretty healthy. So thank you so much. I'm guessing you probably saved a life by just, being on the show with me today. So continue. I just love the work that you do. I love your passion. I love you and your wife and what you're doing to really help people have healthier lifestyles for the sake, to your point, that we can get old but be healthy as we age.
That's right. I think, as you get past 40, on the other side of 40, you start to think of life a little bit differently and try to, spend some time trying to reverse all those misdeeds you did in that first 40 years. And you begin to realize that you really want to be around and be functional. And so I talk to a lot of people, they don't necessarily care about their absolute age when they die, but they do care about one thing, is they want to live a very full life, and they don't want to be in a nursing home for 20 to 30 years of their life. And unfortunately, I'm seeing that far more these days than I've ever seen it before, because our technology is so good. I mean, in the emergency room, if you get to me, chances are we're going to keep you alive. Now, what your outcome is going to be is another thing. And that's really what we want to avoid here, and give people the best life. That's really what I think we're all passionate about. And I appreciate everything you do in being able to help get the message out. Thanks for having me.
Well, thank you so much. Thanks for your time, Alan.
Okay. Bye-bye.
Bye-bye.
And so ends another episode of the Wealthy Life podcast, where Krisstina brings you unconventional, cutting-edge strategies from leading experts to optimize your wealth and your health. As a token of gratitude for listening, go to podcast.fallingformoney.com and download a free copy of her best-selling book, Falling for Money. If you're ready to change your relationship with money, head on over to podcast.fallingformoney.com and download your free copy today.